Hi, I'm Brian Finistine, CEO at St. Clare's Health. Welcome to Let's Talk Health. I'm here with Dr. Neil Freeman, Chairman of Radiology at St. Clare's, and our topic today is wellness and screening. So, welcome, Dr. Freeman.
Thank you, Brian. It's a pleasure to be here, and I appreciate the opportunity to speak to our community about a subject that's very important to me.
That's great. So let's sort of jump into it. So right now, people are trying to take more responsibility for their health, and they're going through wellness screenings. Can you talk about that and expand on it a little bit, please?
Absolutely. Let's just talk about what we mean about wellness screening. We can break it up into two words. Basically, wellness obviously is the state of good health, something that we all strive for. And when we talk about wellness and health, we're really talking about the maintenance of good health and promotion of good health. And it's actually, I just want to give a little historical perspective because it's actually a change for the better from what we were doing in the past, in the sense that in the late 20th century, medicine started to acquire all these great technologies, and as a result, we did great things, but we were really focused on disease. So patients would come to the doctor with a complaint or a disease. Doctor, I'm short of breath. Doctor, I have a headache. Doctor, I have a lump in my breast. And at that point, healthcare providers would take out their toolbox that was growing every day with more technology, and they would attack that disease and try to do something about it. And it's more recently, in the first 2 decades of the 21st century, that we've really started to focus more on wellness, which basically means maintaining good health and trying to promote good health before disease progresses. The screening half of the expression, wellness screening, refers to basically tests and programs where we look for disease in patients who are asymptomatic. So instead of waiting for patients to come in with a problem, we look for them before they become significant. So a perfect example of that, something that everyone's familiar with, is the blood cholesterol test. Many people are familiar with that. They go to the doctor draws bloods. One of those bloods is the cholesterol level in the blood and other lipids. And so these are patients that are coming in that feel well. They're just there for a checkup, and we're looking for elevated cholesterol. If it's elevated, then the doctor will inform you that you're at increased risk for heart disease, and they will make some changes and try to do things that will decrease that risk, as opposed to, again, someone coming in with chest pain to the emergency room with advanced cardiovascular disease, possibly a heart attack, at which point damage is already done. So clearly you can see the advantages, and that's the basic rationale for wellness screening. So screening is basically any program or any tests where we're looking at patients who are asymptomatic and trying to basically do two things with screening. One is risk stratification, which is a fancy way of saying, are you at high risk for a particular disease or not? And also looking for early detection, which is to say, is a disease present in you, but at a very early stage where it can be treated much more effectively.
Dr. Freeman, a lot of these screenings do go through the imaging department that you oversee. Can you talk a little bit about, what type of screenings you're seeing, and what I'll say the prevalence seems to be?
Yes, so basically when it comes to screening technologies, it's not all imaging, as Brian is alluding to. There are a lot of laboratory tests that are screening tests, and there's also genetic testing, which is a kind of screening to look for patients who are at risk for certain diseases. And really, the original screening test really is the history and physical that your doctor does every year. If you are well and you go to your doctor once a year for a history and physical, and the lab tests that they do, that is really the most basic screening test. But in terms of imaging, which is the subject of, obviously, that's dear to my heart, but in imaging, we have developed some significant and very important screening programs and screening technologies. The one that is most familiar to everybody is mammography. Mammography is the largest imaging screening program that exists. It's estimated that approximately 40 million people every year in the United States alone undergo screening mammography. And so, true to the concept of screening, these are patients who have no problems. They don't feel anything in their breasts, they don't have any symptoms, and their doctor finds nothing on physical examination, but they come in for their screening. And one of the things about screening programs is that it's important that there is evidence and data to support the way that we do screening, and that the evidence and the data dictates how we do the screening and who we screen and when we screen. These are all important factors.
So, Dr. Freeman, we're talking about breast cancer. What are the guidelines in terms of ages and frequency?
So it's important with screening programs that we follow certain guidelines that are evidence-based. And in screening in general, the concept is that you want to screen people who have a reasonable chance of having the disease and not screen people that are unlikely to have the disease. So in the case of mammography, the American College of Radiology, for one, recommends that annual screening begin for all women at age 40 and be continued until age 74. So other reliable medical societies, such as American Cancer Society, have slightly different guidelines. Sometimes these different, the proponents of the different guidelines argue a little bit, but they're all pretty close. So here at St. Clare's, we recommend the American College of Radiology system. It's very simple: start at 40, go to 74 every year. And the reason for screening and the benefits of screening are as follows. Cancer that's detected earlier has a much greater chance of being cured. So it's been firmly established that patients who undergo screening mammography have a much lower, significantly lower rate of death from breast cancer than do women who are not screened. So there's data to back up that there's greater survival. In addition to greater survival, it's important, there are other advantages to catching breast cancer early. For one thing, the treatment can be not as severe as what is required for more advanced disease. So in mammography, we can detect cancers that are only a few millimeters in size, and very often those, when they're treated, they can be removed with a very small excision of a small amount of tissue from the breast. They may or may not need some radiation therapy, and they often don't need chemotherapy, which is a huge difference. Patients who are detected with more advanced disease, that present with more advanced disease, much more likely to need either mastectomy or a larger excision. They're definitely going to need radiation therapy, and they almost definitely will need chemotherapy, which is a huge difference. So the mammography is really kind of like the classic example of screening, and that's our biggest program.
How about lung disease? Is there screening for that?
Yes, there is screening for lung disease. It's newer, but it has really grown in the last few years. So the screening test for lung cancer is a low-dose CT scan. And so basically, it's a computerized X-ray image. It uses a lower dose than for a standard CT scan because we're anticipating that those people that are going for the screening program will likely come back every year, or we hope they'll come back every year, so we don't want to accumulate a large dose of radiation. So we use a very low dose. And the parameters are very well worked out, similar to mammography, for who should be screened. And I'll explain the rationale. So basically, for lung cancer, we're screening people who are at high risk. So we're pretty strictly talking about smokers. And the criteria right now, which have just recently been widened to a greater number of people, the criteria right now is anyone from the age of 50 to 80 who has a smoking history of 20 pack years or greater, and who either continues to smoke or who has quit smoking in no greater than 15 years, meaning that if you quit smoking more than 15 years ago, you really don't qualify. But if you're 50 to 80, greater than 20 pack years, you've been smoking at some point in the last 15 years, you qualify to be screened. And patients will undergo this low-dose CT scan, and we're looking for small masses in the lungs. And again, similar to mammography, if the disease is caught early, you have a much better, greater chance of survival. Lung cancer is the leading cause of cancer death, more than any other, including women. More women die of lung cancer than die of breast cancer. So it's a very important disease, and it's harder to cure than breast cancer in general. And so it's even more important to catch it early. And there's already data showing that there's patients who are screened have approximately 20% lower rate of death from lung cancer than patients who are not screened.
So Dr. Freeman, let's say it's been 20 years since you had your last cigarette, although you're an active smoker. Those patients would fall off in terms of the need or the success level for screening?
That's correct. So they wouldn't really, the rationale for it is that their risk is considered low enough that it doesn't make sense to screen them. If someone is nervous about it and wants to be screened anyway, most places do offer a self-pay option where your insurance won't cover it, but you want to get it done anyway. You have to have a prescription from your doctor. And so it is still available for people who are, maybe it's the worried well, I don't know, but you can't really blame someone for being concerned.
But it also talks to, if you quit smoking, you're very much reducing your probability or possibility of getting lung cancer. So
absolutely.
It's a good cause and effect.
Yes, absolutely.
I've also been reading there are some new technologies on cardiac screening. Can you talk about that a little bit, please?
So there's, more recently, there's an imaging test that does screening for coronary artery disease. And what that's called is the cardiac CT scan for calcium scoring. So the way that works is basically, what is coronary artery disease? It's buildup of cholesterol and other lipids in the coronary arteries. And that leads to blockages in the coronary arteries, which can cause heart attacks. So it just so happens that and that's also the process that most people are familiar with, called atherosclerosis. It turns out that atherosclerosis very often is accompanied by calcification of the walls of the artery. So these plaques that are built up are very often contain calcium. X-ray and CT scans are extremely sensitive for the detection of calcium. So the CAT scan it's a very simple CAT scan. There's no injection of contrast. There's no preparation. The patient lies on the table for no more than about 5 minutes. The actual scan is only a few seconds. And the CAT scan basically scans the heart in a special way, and then the amount of calcium in the arteries is quantitated. And there's enough data available now that we know that we can score the calcium. Basically, it's on a scale of if you have a score of 0, that's very low risk. Then we have a category of 1 to 100, and then a category of 100 to 400, and then greater than 400. Obviously, the higher the score, the greater your risk. So basically, it turns out that it's not at all perfect. And it doesn't tell you whether you do have blockages in your coronary arteries. You can have calcified arteries with no blockages, and you could also have non-calcified arteries that do have blockages. But the correlation has been established that based on the score, we can tell you a probability, a risk, a future risk of developing a cardiovascular event in the future based on your score. And so, basically, as I said before, screening is either something that's risk stratification, and we use that information to modify what you do, give you medications, maybe go on to more advanced techniques for diagnosis, and that fits this model. So basically what happens is if your score is low, if your score is 0, then, and depending on your blood cholesterol and other factors, you may basically get the good housekeeping seal of approval that you're okay. Mm-hmm. If you have some intermediate level score, maybe your cholesterol is a little bit high, but it's not too bad, your doctor may will advise you to modify your lifestyle, quit smoking if you smoke, check your high blood pressure, look for diabetes, change your diet, and then lately, most importantly, is use a statin drug, most likely to lower your cholesterol. If your score is very high, then you may need more advanced imaging or actually intervention beyond just medication and lifestyle change. And I just want to quickly add that, because there's sometimes some confusion, there are other advanced imaging techniques for looking at coronary artery disease, but they're beyond screening. So basically there's now a CT scan, a CT angiogram available, which is a non-invasive way of looking more closely at the coronary arteries and actually looking for blockages, and that involves a contrast dose. But that's not a screening test. That's something that if your risk factors were high enough, or if you have symptoms, that your doctor may go on to a more advanced test. So it's like an advanced
screening test.
It's an advanced screening test, and it's something it's more than screening, and it's something that your doctor would have to order based on your situation.
Now, how about the other age guidelines for the cardiac screening?
Basically, yes. I mean, it's typically patients that are 40 and over. However, if someone has other risk factors, like a strong family history of heart disease, or their lipids are high, there's really no lower limit that you have to go by. You can do it at any time. In general insurance, a lot of insurances don't cover it, but the cost is relatively low. And so it really isn't, it's not like an official program where we have official guidelines, but just kind of general recommendations. It's really more a matter of your primary care doctor determining that's going to help them make decisions, and certainly a lot of times it'll be ordered by a cardiologist.
When you say over 40, is that generally an annual screening as well?
No, there's really no set time on that, but annual is probably too much. It's something that's going to change very slowly over the years. I don't know of any guidelines or recommendations, but annual probably would be too much.
Okay. Now, one of the other screenings is for colon cancer screening. Probably not a very pleasant experience in terms of the preparation for the procedure, but there are alternative imaging studies for that. Can you talk about that a little bit?
Yes, the colon situation is interesting. So basically for many, many years, the last 30 or so years, colonoscopy has really been the gold standard for screening for colon cancer. And colonoscopy is what do I call, a minimally invasive procedure. It is invasive. A tube is put into through the rectum. The tube goes through the entire colon. And it does require sedation, and there is a small but definite risk of perforation of the colon. So it's a moderately invasive procedure, generally well tolerated, and that's really the gold standard. More recently, we've developed a CT scan where the colon is inflated with air or carbon dioxide, and contrast is usually injected in most cases, and a CT scan is done. And it's sometimes called virtual colonoscopy because the computer allows the radiologist to actually sit at a computer console and use a joystick and almost looks like the same kind of picture that a gastroenterologist would see as they look through the colon with a colonoscope. So we sometimes call it virtual colonoscopy. So it turns out that the test is very good for the detection of polyps, which is really what the main purpose of colonoscopy. The disadvantage is that if you have a real colonoscopy, the gastroenterologist will actually remove the polyps when they see them, and will get an absolute tissue diagnosis. If they see a mass, they'll biopsy it. If they see inflammation, they can biopsy that. These are all things that obviously are not being done with a non-invasive CT colonography. So it's really a more limited procedure in that sense. But if you have a CT colonoscopy that's negative, then you don't really need the real colonoscopy, and you avoid that additional level of intervention. So I'd just like to clarify one question or potential misconception that people have about CT colonography, which is people wonder about the prep. A lot of people say that for colonoscopy, the worst thing is the prep, and they're hoping to avoid that with the CT colonography. The sad fact is that you actually do have to clean out your colon completely, and the prep is basically the same thing. So if you don't sign up for CT colonography because you think you're going to avoid the prep, you actually are not going to avoid it. And then maybe the most important thing, or is not really the most important, but something that may be very important to people, is the fact that CT colonography in New Jersey, by and large, is not being paid for by insurance. So actually, it's here at St. Clare's, we did a fair amount of CT colonography over the last 10 years, but the last few years we've done very, very few because insurance is not paying for it in New Jersey for the most part. There are specific indications where they will pay for it, such as if you had a colonoscopy that was failed, like they couldn't pass the tube, but that's not really something that's going to be applicable to most people.
Now, how about, in a different vein, I hear about full body scans. Can you talk about that a little bit,
Yes,
please?
full body scans is an interesting topic. So what we're referring to, there's a number of medical practices and imaging centers across the country, and there are several here in New Jersey, that are offering whole body CT scans. Today we've talked about some CT scans that are used for screening, such as CT scan for lung cancer, CT scan for calcium scoring. So they're offering a whole body scan. You come in there and you lie on the CAT scan table. It scans you from head to toe, and basically, every organ is evaluated. And the idea is that they're looking for anything wrong with you that may be significant. So obviously, occasionally, I'm sure that it can be beneficial. There's no doubt that occasionally something important will be picked up. However, I will say that there is no medical society that endorses this practice and that recommends it. And the reason, there are downsides to doing this kind of practice. One is that there is a very high chance of getting false positives. False positives mean that we find something, but it's actually not something important, or it's something that's benign. But we find little things. If you can imagine, we're looking at every organ in the body, and the chances of getting through your entire body without finding some little thing are actually somewhat small. So we find some small thing, and then what's next? Well, very often you have to do other imaging studies or more advanced imaging studies to evaluate it. So I sometimes joke with people when these situations occur, and I say, well, basically, one good test brings on another. So basically, you end up having to do more tests to evaluate, or maybe they're recommending follow-up. So, well, there's something in your liver, but we don't know what it is. We don't think it's anything, but now you have to have a scan in 6 months to make sure it didn't grow. And now you need another scan in a year and 3 years. And if you've had 4 scans over the next 5 years and we see that it hasn't grown, then we know it's okay. Or worse yet, that we really don't know what it is, and then you have to have a biopsy. Of course, again, there is a chance that something important can be detected early, and that would be beneficial to the patient. And we see this sometimes in other scans that we do. Patients come to the ER for appendicitis, and we find something in their left kidney that saves their life. So that can happen. But in general, your chances of having false positives are much, much greater than actually finding something significant. And then there are no guidelines, because how often are you going to do the scan? Can you do it if you do it once and you don't do it for the next 10 years, it's almost worthless, because you could develop many things over the next 10 years. On the other hand, are we going to do this every year? No one really knows. And if you do it every year, you're going to be finding more and more things that need to be followed, and more false positives. And it can be basically a slippery slope. So we don't offer that here at St. Clare's. We don't recommend it, and I don't really know any reliable medical society, or there's no data to support this practice.
Okay. So, St. Clare's is about around the corner ahead of the curve. So we're into the fact that patients want to stay local, and we believe we do that, better than most organizations. We make people feel comfortable, they're respected. We also, in terms of ahead of the curve, we've got some great new technologies. So could you talk about that so that the viewers have an idea of the technologies, and again, back to the screenings that we can in fact do at St. Clare's?
So Brian, basically all of the standard screening programs that are out there are available at St. Clare's. So to begin with mammography, we have we offer mammography at the Women's Health Center and at the Dover campus, and we have mammography at the Imaging Center at Parsippany Commons. And I just want to add that if you're going for screening mammography, I recommend that you go to a center that is accredited by the American College of Radiology, which all of our centers are. So we offer state-of-the-art mammography with what's known as tomosynthesis or 3D. That's an added new technique to mammography that is not really required by anyone in particular, but most people want it now, and I think in the end the data will support that it is beneficial. It's just a technique where we can see more into the breasts. We also offer something that I didn't mention before that I actually meant to mention was there's also the issue of screening ultrasound for breast disease, which is recommended for some women, basically women with dense breasts. So we offer that, of course, at our two centers. And they're highly developed centers with great staff, and I think we do a great job with breast screening. We have a very well-developed lung screening program. These are also ACR, American College of Radiology, designated centers. We offer that at 3 sites, the Dover campus, the Denville campus, and the Imaging Center at Parsippany Commons, all 3 American College of Radiology designated sites. And we have a great program. We have a great nurse navigator who's in charge, and I'm proud of the work that we've done there. Cardiac screening, calcium scoring, we offer again at all 3 campuses, Denville, Dover, and Imaging Center at Parsippany Commons. We do state-of-the-art calcium scoring. And then additional screening that's available is we do screening for at St. Clare's for carotid artery disease, which we didn't mention, but I'll just quickly mention. It's an ultrasound examination, completely non-invasive. It's indicated for certain people. It's not for everybody, but if you have high risk, it's basically looking for carotid artery disease, which can lead to stroke. We do that in Denville and in Dover. And then finally, the lung screening, the CT colonography, we do offer it in Denville, but again, we have the insurance problem. So that's sort of like on hold for now, although we are actually very able and experienced at doing that procedure.
So again, we are in fact around the corner, ahead of the curve for all of the home screening, the screening needs for wellness for our patients.
Yes.
You mentioned one other thing I didn't want to gloss over. You talked about a terrific nurse navigator. Do you want to talk about that concept, please?
Yes, we use the nurse navigator in several areas. In terms of screening, we have a nurse navigator for lung cancer, for the lung cancer program. And we have a nurse navigator for the breast imaging program. And basically, the nurse navigator is basically kind of like a liaison, making sure that patients get through the system and have the right things done. The nurse navigator basically works between the referring doctors, the patients, and the radiologists, and basically knows that these people are very well educated. They really know, they're very well trained. They know the disease process and the diagnosis and the procedures in and out, and they basically shepherd the patients through the different experiences that they will have if they need more than just your basic screening test. And it's a great resource. We also have it for our thyroid cancer program, which is not a screening program. We're not talking about that today, but we use that in other areas as well. And it's a great advantage to patients.
Okay. Dr. Freeman, thank you. Great information for our viewers. And again, everyone, thank you for watching Let's Talk Health. Please look for some future events. Follow us on Facebook, on YouTube, and again, further information on our website, stclares.com.